Can you hear us? Can you hear us?
Okay. So I think we can start, right?
Yeah.
All right. Good afternoon, everyone.
Check this yourself. Okay, just come to the camera.
Okay. All right. Good afternoon, everyone. Welcome to today's session. So our topic today is on hypertensive crisis. My name is Dr. Mona Eze, and my colleague is
Dr. Mariam Inuwa.
Yeah. So it's good to be here today. So we'll just go ahead to talk about hypertensive crisis. This is a very common occurrence in our everyday clinic and practice. It's something that almost every one of us, if not all of us, have actually, come across as often as possible. So this term is used to define hypertensive urgency and emergency. We know that hypertension is actually very, very common in this part of the world, especially in Nigeria. The prevalent rate is up to 38%, amongst adults in Nigeria. And it's estimated that about 1% to 2% of patients with chronic hypertension will at some point in their life develop hypertensive urgency or emergency. Now, hypertensive emergency is a life-threatening complication of high blood pressure and may be a patient's first presentation. We should bear that in mind, that it might just be the first time a patient is presenting maybe at your clinic or practice is with, he or she might present as hypertensive emergency. So what does this tell us? Always check your patient's vital signs. Make sure you check blood pressure, whether you're treating malaria or a UTI, you must check the blood pressure. Okay. So we have a few objectives. Objectives. In patients with severe hypertension, primary care clinicians must be able to distinguish between hypertensive urgency and a true hypertensive emergency. It's very, very important. Why primary care clinicians? I'm stressing this because most of these patients will come to you first. You come to a primary care clinician, and then you should be ready and know what to do at all times. So there are questions you have to ask yourself. Can I manage my hypertensive patient as an outpatient, especially those that present as an emergency or urgency? Should I admit and manage as an inpatient? Should I admit in ICU, and at what point should I do all this? And then what do we do after making a diagnosis? That's another dilemma. You should know what to do. You should know the appropriate medications to also give. And then when to refer, maybe to a higher center if your center is not well equipped or capable enough to handle such a case. You should also know when to refer. Okay, Dr. Inuwa.
So going through, let's start with a question just to prep our mind and to prepare us to understand what hypertensive crisis is all about. So what is hypertensive urgency, or what's the difference between hypertensive urgency and emergency? So what is the difference? So A is high blood pressure, how high the blood pressure is or not, how sick the patient is or not, that's B. And C is there acute organ damage or not, D is if the patient is unconscious or not, or all of the above. So please, you can put your question, your response, your answers on the question and answer column, either A, B, C, D, or E. Let's have an idea of what you think is the difference between hypertensive urgency and emergency. And then at the end of today, we would know if the answers are right or wrong. So we'll move on with the first case.
Okay, so case one. This was a case of a 40-year-old woman who presented here in our facility here at Cardiocare. She was a non-hypertensive and presented to the emergency with elevated blood pressure of 2 weeks duration. Actually, she has been on her medications prior to her presentation, but there was no symptoms. She was symptom-free, no headache, no slurred speech, seizures, dizziness, chest pain, palpitations, or shortness of breath. And then she had been to a peripheral hospital earlier on and was placed on medications on account of severely elevated blood pressure. And she was a newly diagnosed hypertensive of just 6 months duration. So she felt she could just be on the medications that she was placed on initially, hoping that the blood pressure would come down, but it never did. So her medications were tab amlodipine, 10 milligrams daily, and tab indapamide, 1.5 milligrams daily. So on examination, she was not in distress. She was afebrile, not pale, anicteric, cyanosed, not dehydrated. There was no pedal edema. Cardiovascular examination, pulse rate was 75 beats per minute. It was full volume and regular. It was actually synchronous as well. Blood pressure was 206 over 115 millimeters of mercury. There was no raised JVP, that is the jugular venous pressure. Apex beat was at the 6th left intercostal space, anterior axillary line, and heart sounds was 1 and 2. Respiratory system and the central nervous system was not remarkable. So some investigations were also carried out, cardiovascular profile, which includes kidney function test, uric acid urinalysis, lipid profile, and then an ECG and echo was also requested. So the question is, okay, so the question is, what is the diagnosis? What do you think the diagnosis should be? Should it be is it a hypertensive emergency? Is it malignant hypertension? Do you think it's hypertensive urgency? Do you think she has severe preeclampsia? And then hypertensive encephalopathy. So also drop your answers in the chat box. All right, Dr. Inuwa.
Okay, so the whole essence is for us to understand what hypertensive crisis is all about, because we all know that a lot of people present with high blood pressure to our clinics. And then there's that dilemma of, oh, what do we do when it's at this particular level? And what medications do we give? Because it makes a whole lot of difference. But we need to clarify from the very beginning when this patient presents, what are we dealing with? What type of hypertension are we dealing with? So let's clarify terminologies. Hypertensive crisis is known as an elevated blood pressure of over 180 over 120. So if you're getting anything above 180 over 120, you should be considering hypertensive crisis. And then there's some terminologies we're used to or we've always known, like malignant hypertension, accelerated hypertension, but they are now all under either hypertensive urgency or hypertensive emergency. So once we see a patient, the question we're asking ourselves is, this blood pressure is markedly elevated. Are we dealing with urgency or emergency? The main thing that differentiates the two is any sign of end organ damage. So with urgency, there is no sign of end organ damage. That means this patient comes to you, you've asked all the necessary questions, no complaint at all, just the elevated blood pressure. Regardless of maybe the person is hypertensive or not, as long as that person is presenting with elevated blood pressure, no sign of end organ damage, then we're dealing with an urgency. But once you can pick any sign of end organ damage, which we'll discuss as we go on, then we are dealing with an emergency. So hypertensive urgency and emergency are differentiated by the absence or the presence of end organ damage. So that is why it's important to take a quick history, especially when it's an emergency, to be able to differentiate what we're dealing with, because the mode of management is totally different.
Yeah.
Then, so hypertensive urgency is defined as, especially when you're seeing your diastolic is above 110. First of all, we know that yes, we're dealing with hypertensive crisis when we have 180 over, above 180 over 120. And then you're not seeing diastolic blood pressure above 110 without signs of end organ damage. Emphasis on without signs of end organ damage. Some sources suggest that a patient may also have certain risk factors. The person might be known to have other comorbidities. The person might have a background renal involvement or heart failure. The person might be known hypertensive, might have other pathology, but as at when the person is presenting, there is no sign of any end organ damage with elevated blood pressure. The presence of acute and rapidly evolving end organ damage with an elevated blood pressure then becomes an emergency. So this person comes with symptoms that suggest an end organ damage. It's an emergency because something needs to be done. If not, it's going to get worse. Whatever organ that is affected would get worse, and the chances of having a mortality on your case, as in mortality on your hands, is quite high. So no specific blood pressure measurement indicates a hypertensive emergency. However, rather, the defining feature is that of end organ damage. So once you're picking signs of end organ damage, then you're already thinking of an emergency.
So, sorry, it's important to stress what Dr. Inuwa just said about no specific blood pressure measurement indicates a hypertensive emergency. What does that mean? Assuming a patient comes to your clinic with a blood pressure of 160 over 100 and has some focal neurological deficits or CNS symptoms, you won't wait till blood pressure is 180 over 120. So what I'm trying to stress here is that 180 over 120 is arbitrary. So you need to individualize patient management, personalize management, and don't generalize. So it's important to know that there's no particular measurement. Remember the case I mentioned earlier, blood pressure was what? It was over 200, the systolic was over 100. So management is determined by on person per person basis. So you don't just generalize waiting till you get to 180 over 120 millimeters of mercury. That's important for you to know.
In the setting of the end organ damage.
In the setting of the acute end organ damage, which is the defining feature.
So for hypertensive emergency, a lot of things should be going on through our minds. Once you're seeing an elevated blood pressure, you want to find out, are there signs of end organ damage? And those signs are things that should be on your mind while you're clicking, because you want to take a quick history to decide on what next to do. You might not be so detailed about the history, but just picking up some important information will determine whether you're going to treat as urgency or as emergency. So what are those things that define or are under hypertensive emergency? You have hypertensive encephalopathy, acute stroke, aortic dissection, pulmonary edema, myocardial infarction. It could be post-operative bleed coming with elevated blood pressure, acute renal failure, could be somebody that has retinopathy, or a pregnant woman with eclampsia. So some of these things should be going on through our minds, but we should also know that there are other things that can also mimic hypertensive emergency. So we call that pseudo emergencies. So we need to quickly also rule that out when you're taking a quick history. Emphasis on quick history because you need to do something urgently, because this is an emergency if you're considering an emergency in this case. So some other things you might want to rule out is the pseudo emergency. And this comes about when you have acute rises in blood pressure attributed to either a physiological trigger that would cause massive sympathetic surge. It could be from pain, hypoxia, hypoglycemia, anxiety. So you need to quickly, because we had a case recently that just came to the emergency. It was a woman, she just gave birth some few days ago, and then she checked her blood pressure. She has been so stressed up, taking care of the new baby. She didn't really have anybody to help her at home and all. And then she checked her blood pressure. It was 170, and when she came to the hospital, she was panicking. She was in shock. We had to calm her down, went to the emergency. But within some few minutes, we checked again. The blood pressure had dropped to 130. So we need to rule out anxiety, rule out pain in some situations where you're suspecting a pseudo emergency. These scenarios must be differentiated from true hypertensive crisis because the management differs. Treatment in cases like this is now targeted at whatever is causing the anxiety, not just antihypertensive medications. But in some cases, you might have to include antihypertensive medications.
Then another common example is post-surgery.
Yes.
Pain post-surgery.
Yes.
We have patients in the hospital, in different hospitals right now that had surgery, not a known hypertensive, no cardiovascular risk factor per se, but you check blood pressure, immediately the patient comes out of the theater. Are you going to start giving antihypertensive immediately? No. So this is what we're trying to stress here. You need to find out what the underlying factor is and treat it. If it's pain, you need to give appropriate analgesia to bring down, to reduce the pain, and as well as reduce the sympathetic or catecholamine surge that leads to increased vasoconstriction, thereby increasing blood pressure in the long run. So it's very, very important to know that.
So moving on, what's the pathophysiology of all of this? We all know that blood pressure is cardiac output and total peripheral resistance. And total peripheral resistance is influenced by humoral and neural factors. And during an episode of an acute hypertension, there's failure of the autoregulatory function. And that is what causes resistance in the systemic vascular bed. So once there's elevated blood pressure, there's endothelial damage, coagulation cascade come into play, fibrin deposition, all that deposited in the arterioles of organs and can reduce perfusion to those organs. And that's how we then end up with end organ damage. So the main concern regarding organ hyperperfusion is that it can lead to ischemia of that organ. So that's why it's always important that with end organ damage, we need to halt the process going on by reducing that blood pressure urgent immediately.
Okay, so just like Dr. Inuwa said, this pathophysiology is actually the basis for this discussion. We need to understand the pathophysiology of hypertensive crisis so that we know when not to intervene and when to intervene. So just like she said, it all ends with target end organ damage, okay, or what we call hypertension modifying organ damage. So in this instance, we have a flow chart here that summarizes all that she had said. When a patient has a very high blood pressure, what happens to the vessels is that there is intense mechanical stress on the vessels, and this will lead to endovascular injury. Then the endovascular injury triggers release of inflammatory markers, and before you know it, there is pro-inflammatory markers released, there is pro-thrombotic markers released as well, leading to fibrin necrosis of arterioles. So those end arterioles are supposed to perfuse organs, are necrosed. So there is reduced perfusion or hypoperfusion of the organs. All right. So something like the kidney will be hypoperfused, and this will trigger the renin-angiotensin aldosterone system, and it becomes a vicious cycle. The renin is released from the juxtaglomerular cells, and then what happens? It converts angiotensinogen to angiotensin 1. Angiotensin 1 is converted to
angiotensin 2
by the ACE, the angiotensin converting enzymes. And we know that angiotensin 2 is a potent vasoconstrictor. Okay, and then it increases increases blood pressure, sodium and water retention, causes the tubules to conserve and reabsorb water and sodium, and this will end up further increase the cycle of uncontrolled blood pressure. The ADH also released from the posterior pituitary also causes retention of water and sodium. And so it becomes a vicious cycle of increased blood pressure triggering, what's it called?
The RAS system.
Yes, the RAS system, sorry, triggering endovascular injury, fibrin necrosis of arterioles, reduced perfusion to the organs, and then the kidney fires up again the RAS system. So it's important to understand this so that we don't go crashing blood pressure when we're not supposed to do that. So what causes or precipitates the crisis? So we're talking about etiology. So we'll look at etiology. It has been estimated that 30% to 40% of patients with a hypertensive crisis have an identifiable underlying cause. Evaluation for such secondary causes and precipitants is indicated in all patients with a hypertensive crisis. There are so many causes, secondary causes, from obstructive sleep apnea to renal pheochromocytoma, renal vascular diseases, renal parenchymal diseases, and so on and so forth. Even collagen vascular disease, like the scleroderma, preeclampsia, and all what. So all this will contribute to the etiology, and we need to also find out these underlying precipitants that contribute to hypertensive crisis. And then there are also several medications and illicit drugs that can cause marked elevations in systemic blood pressure, especially cocaine. Okay, cocaine is one of them, especially in this part of the world where Abuja, to be precise. All right, oral contraceptive, sympathomimetic agents like diet pills and vitamins, cold remedies like pseudoephedrine, some abuse that, NSAIDs, ibuprofen, diclofenac, and the rest. Then tricyclic antidepressants like the amitriptyline, monoamine oxidase inhibitors, etc. So withdrawal from medications and illicit drugs can also precipitate severe hypertension. So the importance of this is taking notes, knowing that in your history, you need to be seen trying to elicit all these precipitants as much as possible. Drug history, comes to play here. Social and family and social history in particular, in terms of drug, use of substances, abuse of over-the-counter medications, and all that. So those are very, very important.
And it's also important to also know if these patients have high blood pressure, if they've been regular on their medications, the last time they check their medications.
True.
Because a lot of times they'll tell you, oh, I've been on my drugs, but they've not been checking their blood pressure. They don't go for clinic visits. So they've been on medications, but they've not been properly controlled on those drugs. So you need to get that history because that is very important. And if for whatever reason they've not been taking their medications, it's always good to know why. Because if you're able to address why they've not been on their medications, you'll be able to counsel them adequately to help them to take their medications regularly. Because compliance is key. We can't be prescribing medications and the patient doesn't take it. At the end of the day, we are not solving any problem because we need to know why so that we can address it. Because some of them just have negative mindset about medications. But when we're able to allay those fears, that would help compliance because that would also avoid hypertensive crisis if they take their drugs regularly with good BP control.
And then for stressing, looking into the factors of poor adherence, that actually brings us to adherence. Because in adherence, you're now going biopsychosocial. You want to know the psychosocial issues surrounding the fact that the patient is not able to take his medications as prescribed. So just to add to what Dr. Inuwa just said about medication adherence, that's very important.
So other factors, we know that the Black race is at higher risk of having elevated blood pressure compared to other races. Then the male gender, low socioeconomic class, we know that because health-seeking behavior for the low socioeconomic class might be reduced compared to somebody else that goes to the hospital, does checkups on a regular basis, not waiting for something to go wrong before going to the hospital, and then of course smoking, all forms of tobacco use, and then oral contraceptives. So when we are taking our history, we need to ask these questions so as to address this hypertensive crisis so that it doesn't occur again. Because if we don't address the problem, it would happen again, regardless of them being on their medications.
Yes. So, but remember that if it's an emergency, you're not going to sit down taking a full history, before
You would
attending
have
to the
sorted out, at
emergency.
least you, first of all, the
Exactly.
major thing, as we said earlier on, is ensure, is there head organ damage or
Yeah.
not? So that we can start treatment.
Yeah.
And then later on, you go back, take this history and see where this patient had issues or what the cause was, and then address it.
Yes. So how is a patient with suspected crisis evaluated? The patient has come to your clinic, you've asked questions, you've taken a history and all that. So how do you go about it? So in a stepwise manner, we know that for every evaluation, you have to start with history. The symptom chronology, okay, if it's chest pain, you want to clock around the chest pain, you want to know the severity, the onset, is it radiating, what are they alleviating, and relieving factors as well. Okay, then you want to also use your 5 Cs, the complaints, the course of the illness. You want to find out the care. You want to find out any complications and so on and so forth. Now, in terms of the blood pressure, you want to find out the duration of the severely elevated blood pressure. Like the woman in question in the initial case I just read out, she had been with it for 2 weeks, severely elevated blood pressure for 2 weeks. But because she had no symptoms, she felt it would just go down. They want to find out medications, like Dr. Inuwa said earlier. What medications has the patient been on? You want to find out about recreational drugs. So this is where you have to be seen asking. Cocaine use, don't be shy. Patients will appreciate that you care much about them to ask those sensitive issues, but then you also need to be polite as you're asking. Don't be judgmental.
Yes,
true.
true.
Don't be don't be judgmental. Ask about the use of marijuana, ask about alcohol intake and all that. And then etiology. So you want to find out possibly, remember we mentioned etiology, all the secondary causes.
Yes.
You want to be seen eliciting it in your history.
Especially in the young, if you're seeing a young patient presenting with elevated blood pressure, secondary causes of hypertension should be ruled out.
Exactly. And then smoking. Smoking is very important. It's a very, 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 important risk factor to address, especially in cardiovascular health. All right. So that brings us to history.
So other things we want to find out in the history is to know which system is involved, because that would help you narrow down to what particular type of emergency you're dealing with, because you need a diagnosis. Knowing that there's a hypertensive emergency, because once it's urgency, we are clear. There's no symptom. Everything is okay with the patient, just the elevated blood pressure. But with the emergency, we need to know which organ is involved, because some medications are preferred over others depending on what you're dealing with. So you want to check the cardiovascular system, our usual, you want to know is there shortness of breath, chest pain, orthopnea, PND, quick neurological examination. You want to know if there's any, of course, if there's loss of consciousness, you get that immediately. But there are times you want to find out, is there irrational behavior, headaches, vomiting, then check, ask if there's reduced urine output, bloody urine, blurred visions. You need to sort out all of that also, because the whole idea is to find out what organ is involved if you're suspecting an emergency. And examination, a fundoscopy is important because it helps us see if there's any retinopathy, if you're seeing papillary edema, and that could also help us to know if there's signs of increase in intracranial pressure. When you do your fundoscopy, you can tell if there's flame hemorrhages, cottonwool spots, and all of that points towards uncontrolled hypertension, and then your cardiovascular examination, you want to check your GAVP is elevated, you want to examine the chest to see if there are crepitations, because you need to rule out pulmonary edema, because person might come with widespread crepitations. You want to listen to the heart if there's any added sounds or murmur, because you have to also rule out heart failure in this patient. You also want to check the blood pressure on both arms, because we're also trying to rule out either an aortic dissection. And then preferably, once you're dealing with severe hypertension, don't just check the blood pressure once. Confirm again so that you're sure that this blood pressure you're checking, or you've got this high blood pressure, is actually elevated, and ensure that because of course we expect that you know the right way to check your blood pressure, so you check again to ensure that, yes, this blood pressure is elevated, then you can listen. Renal bruise is important to also listen for renal bruise.
And for renal bruise, it's important to know where to listen.
Oh,
you
yes.
can, yes, 1 finger breadth or 2 cm, 2 cm lateral and superior to the umbilicus.
Yes.
You place the bell of your stethoscope there and listen for renal bruise. There was something you mentioned about fundoscopy. How many of us carry out Please answer in the chat box. How many of you have carried out?
Actually,
yes.
We're not referring to the ophthalmologist here.
No.
We are supposed to do the fundoscopy.
Yes.
In the emergency room, so as to take a
that.
decision there and
of
then.
Course.
So we should have it there available.
Yeah, and you should know the classification, your Keith and Wagner classification of retinopathy. You should know that from grade 1 to 4, because once you're seeing grade 3 and 4 is an emergency.
Yes.
And this is why hypertensive emergency has replaced malignant and accelerated hypertension, because that's where you see the retinopathy. Grade 4 is seen in malignant hypertension with severely elevated blood pressure of 200 over 120 and above. And then you have for accelerated is grade 3, So it's very important to do that. Please, fundoscopy from today onwards. All right.
So continue with our physical examination. We've talked about checking for your renal bruise and we've explained where to look for it. Neurological examination is also very important. And the importance of this is to differentiate with if you're dealing with encephalopathy, hypertensive encephalopathy, or a stroke, because what you would do is totally different in the two different scenarios. So you need to differentiate hypertensive encephalopathy from a stroke. We'll talk about that later on. Or part of your neurological examination, that should be on your mind. Then, of course, we've talked about focal findings. Are you dealing with ischemic or hemorrhagic effects event? So you're doing your full neurological examination, checking for power, checking for tone, reflexes. Is there facial nerve palsy, any facial nerve involvement? And then no absolute level of blood pressure differentiates an emergency from urgency. We've talked about this, that for emergency, what is important is that you're seeing an end organ damage at that time. So emphasis on the fact that even if you're not getting your blood pressure up to 180, even if it's 160, and the person is coming with hemiparesis, already we know what you're dealing with. You're not saying you're waiting to make a decision whether it has not gotten up to 180. Already you're dealing with a stroke, and that is already an emergency.
So that's why it's important to treat the patient and not the numbers. If you treat the numbers, you're going to be carried away and you do a lot of damage, by the time you're done. So always treat the patient, individualized treatment, and not the numbers. So how are hypertensive crises investigated? So if a hypertensive emergency is suspected, start intensive care unit treatment or a referral process after initial therapy while waiting for the results. So if you know that you realize that this patient will benefit from an ICU care or admission for ICU care, please refer, but then stabilize. Give the initial therapy. Don't just send the patient on his way with a BP of 230 over 150.
That's why we are going through
all this.
That is why we are going
through all this.
So that we know what to do,
exactly.
Depending when you can refer,
Yes.
if you might not have the facility to take care of this person
Yes.
with hypertensive emergency, but at least you should be able to do something before referral.
Yeah. And then full blood count should be done. Please, let's not forget full blood count and the peripheral blood film. Why is this important? Because once there's anemia with schistocytes, it should rate concern for hemolysis and what we call microangiopathic hemolytic anemia. Okay, so this is very, very important. I know we don't routinely do it, but we should actually be doing that. Then hypokalemia and other electrolyte disturbances may give a clue to a secondary cause of hypertension, like the primary hyperaldosteronism, there's usually hypokalemia, and then Cushing's syndrome. Also, the serum chemistry panel, electrolyte urea creatinine, very important. It is warranted to identify any renal dysfunction. So you see how you can also elicit through laboratory investigation, target organ damage. Now, any patient complaining of chest pain, must have an ECG done. Must have an ECG done. ASAP, within 10 minutes, not later than that. So if you don't have an ECG in your center, please tell your medical director after this presentation that you must have an ECG. What are you trying to look for? You want to look for ischemic changes or presence of a left bundle branch block. And then serial cardiac enzymes. We also want to carry that out serially based on presentation to rule out acute coronary syndrome. Then access to previous ECGs can be helpful. If the patient is an old patient or a known patient in your facility, you can go back and look at the previous ECG and compare with the current one. So it helps you to differentiate between new and old conductive abnormalities, especially when you're seeing the left bundle branch.
And you don't know whether it's new or old, because if the person is a known patient with left bundle branch block, they might not be as worried as if this is a new finding, because if it's a new finding, you need to rule out ACS.
Yes, and then chest X-ray should be performed in patients who complain of shortness of breath and or chest pain. Now, on chest X-ray, once you see a widened mediastinum, it can represent aortic dissection. Okay, then evidence of pulmonary edema should prompt the clinician, should prompt you to assess for left ventricular dysfunction or any valvular insufficiencies by echogram. So echocardiogram, very important. If you don't have an echo in your center, that is also something you should be talking about getting. Chest CT should be pursued in patients with clinical suspicion for a dissection. So you've done a chest X-ray. If you have access to a chest CT, that's even better. Then patients presenting with a headache or focal neurologic abnormalities, please, you have to do a brain CT. You have to do a brain CT. It's not, you can't just not do it. You have to do that to rule out a stroke. It also guide your management because you want to rule out hemorrhagic stroke. You want to know whether it's ischemic or hemorrhagic
hemorrhage you're dealing with. Especially when we're dealing with encephalopathy, you're not sure.
Of course.
Is this just pure hypertensive encephalopathy, or the irrational behavior is still, or seizures the person is having is still part of a stroke, maybe ischemic or hemorrhagic? You need to rule that out. So you need a brain CT urgently.
True. And then the urine drug screening test.
Yes.
Most of us have it in our facility, but we don't really request it. How many of us have screened our patients, for drug, have carried out a drug screen? It's very important, especially the younger ones that are presenting by 2 a.m. with chest pain. You have to rule out, especially when the history is suggestive of illicit drug use. So those are very, very important investigations to carry out. So prior to initiating treatment, especially in hypertensive urgencies, well, do we routinely do this? Maybe not, but if we can, you should obtain renin and aldosterone level measurements, and then serum and urine metanephrine samples. It also helps us to rule out secondary causes of hypertension like pheochromocytoma. And then many of the medications used to treat hypertension, like the beta blockers, diuretics, the ACE, confound the interpretation of this test if you don't take the samples prior to commencing this investigation. So these diagnostic evaluations should never delay treatment. Like I said, or we said earlier, you shouldn't just go carrying out tests when you can save a life and then do the other things later. So your clinical judgment also come into play in making a diagnosis of hypertensive emergency.
Yeah. So you're taking your samples, it's been sorted out in the lab, you're sorting out the patient, because you've taken a decision whether you're dealing with emergency or urgency. It's not just based on investigations. The investigation is just supposed to pin down what you think is really going on so you can address the cause. But you're taking your samples, but we've started blood pressure management already in this patient. So how do we treat? So in treating, as we said, we need to understand, is it emergency or urgency? The treatment varies. Aggressive blood pressure control in patients presenting with acute ischemic stroke has been associated with poorer patient outcomes. So don't be too aggressive with blood pressure reduction. We would explain further the rate at which you should reduce the blood pressure, because at times we get so carried away. Oh, this person presented with 220, crash the blood pressure. This is bad, And at the end of the day, you worsen the patient's condition because the body is already used to that high pressure. So you need to gradually reduce that blood pressure depending on what you're dealing with. Because of the loss of autoregulation in the brain, you have to gradually reduce it depending on what conditions, which we'll discuss, as I said, later on. So treating the patient and not the numbers, as we keep saying, we are dealing with the patient. What does this patient have? Have we confirmed as a stroke, or is it an encephalopathy, or is the person in heart failure, or are we dealing with myocardial infarction? That's what we're dealing with, not just the elevated blood pressures, because that will guide what medications to give. So just treating the patient and not the number is the first general recommendation for the treatment of hypertensive crisis. It is important that we do no harm. We know that is our Hippocratic oath. So we keep saying it over and over. No sublingual nifedipine. We don't know how else to overemphasize that, to put it up there boldly.
True.
No, because a lot of people are so quick. Oh, they're struggling to get the line, just put something under the tongue, you know? But the side effect of this in the long run worsens the outcome. It crashes the blood pressure. You know, you don't have a good control of that blood pressure and you make matters worse, cause worsening of neurological deficits. And it's a no-no. We keep saying it over and over. Don't do it. We have other medications we're going to go through that you can use to reduce that blood pressure, but no sublingual. Sublingual. We have nifedipine in oral forms, but not sublingual.
It wasn't the hypoperfusion that we talked about.
So we've said it again, instantly crashing down blood pressure that was very high is very bad. It's not a good idea. So we should be careful because it happens a lot. This blood pressure is too high. In short, at times the mercury sphere is not even picking anything. It's going higher than that value and still pumping up, you know. Be careful, even as much as we are going to bring it down, by the time we get to other aspects of treatment, we are not going to just crash it. So what we recommend is reduction in the mean arterial pressure of about 10 to 25% in the first hour. So that's why we like giving antihypertensives that we can control. So once we are giving the IV antihypertensives, we can control what dose we are giving and what blood pressure we can get. So the aim is within that first hour, we want a 25% reduction. So, and then within the next 8 hours, the next goal blood pressure target is 160. And then subsequently, in the next 24 hours, it can then normalize. So that is why we like using medications that we can control, so that we know when to stop, when to increase, when to add something else, rather than medications like nifedipine that just goes into the system and you have no control over it subsequently. So this is an algorithm just guiding us to what to do once there's an hypertensive crisis. We've talked about it, trying to rule out, is it urgency or emergency? So if you're sure there's no end organ damage, then we are dealing with an urgency. That can be managed, not necessarily on admission. You know, you can place on medications, but the person needs close follow-up, and you need to know the etiology so that you can address it. If it's that the person wasn't taking medications as he should, or not appropriate, or was missing whatever dose, you can adjust and address it appropriately. But if you're dealing with an emergency, then you need, this patient needs to be admitted in ICU, where the patient will be on IV medications and blood pressure monitored and not crashed.
Yes, and very important to know is don't treat the patient in isolation.
Yeah.
Most of these patients comes with comorbidities, multimorbidities, might be diabetic, you know, or asthmatic. So those will also guide your choice of medication. IV labetalol shouldn't be given to asthmatic patients. So the important point here is don't just focus on the blood pressure. Also find out if there are other comorbidities that the patient also has.
Very important.
Yeah. So for treatment of hypertensive urgency, the treatment of hypertensive urgency is usually immediate and it warrants close follow-up. So although the elevated blood pressure can be alarming, the patient is already anxious. Oh, the doctor, what's my blood pressure? Oh, 200 over 120. You, the doctor, would know better, you know, and allay the patient's anxiety. You know, remember that this is a gradual rise in blood pressure over days to weeks. So in this setting, it's not necessary to lower blood pressure acutely. A rapid decrease in blood pressure will cause symptomatic hypertension, resulting in hypoperfusion to the brain, reducing cerebral perfusion. I know what will happen. So after ruling out end organ damage, the next step is to treat according to the guidelines for hypertensive urgency. So after the short-acting agent that you've already given has reduced the blood pressure, it's very important for long-term agents to now be used to prevent rebound hypertension. And this long-term agent should be monitored. Give a short appointment. A patient comes to your clinic today with hypertensive urgency. You've brought down the blood pressure to reasonable level, right? You want to send the patient home after observing for maybe up to 24 hours or less, depending on the presentation. Don't just send the patient home and tell the patient, come and see me next month. No, give an appointment, short appointment, can be a day or two. See me tomorrow, or even see me in 48 hours with blood pressure readings. Why is that important? You also want to, keep a close watch on the rate of blood pressure reduction over that time frame before you can now give a longer appointment. So patient education is very key. Patient education is very key. If you don't take anything home today, educate your patient. That should be your mantra. Because most of them are not well informed. We've not educated them properly. We've not counseled them that hypertension is a chronic disease. And more often than not, you're going to be on that medication for a very long time. We need to stress that. We need to stress the need for adherence. We need to stress the need for regular clinic visits as often as possible. We need to teach them self-care. They should try and get blood pressure monitors to be apparatus to be able to check their blood pressure at home, and then know when to report to the hospital immediately in case of an emergency. We need to teach them lifestyle. We need to teach them, what not to eat, what, smoking cessation if they are smoking, alcohol, no alcohol intake. That's a new teaching.
Yes,
used to be
no
moderation.
Alcohol,
no alcohol intake
alcohol
at all.
Yeah.
Reduction in salt intake, not more than 2.3 grams in 24 hours. Increase fruits and vegetables. Let it be a mantra. No hypertensive patient should come to your clinic after you've prescribed medications. You send him home without telling him or her about lifestyle modification measures. Is very, 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 very important, and a very good aspect, an important aspect of the treatment. So these recommendations.
Sorry, just to add to what you just said, because a lot of times we see them in clinic, they'll say, oh, my blood pressure was normal and I stopped my medication because I'm cured,
Yes.
So you need to explain that this blood pressure medications you're taking is what has regulated this blood pressure to the normal range. So you have to be on it regularly to maintain that. So that's why we keep emphasizing on education. If they're well informed, they will do better with their BP control.
Yeah, and then prevent complications.
Yeah, exactly.
So these recommendations include the use of rapid onset, like we said earlier, rapid onset oral antihypertensive agents like clonidine. Clonidine might not really be so available, but we have labetalol,
readily available.
Yeah, nifedipine. And the use of this agent is only suggested for gradual short-term reduction of blood pressure, like over 24 to 48 hours, before you now give the longer ones like the ARBs, the ACE, the calcium channel blockers, and the rest of them. Now, the patient is being monitored for potential hypertension-related organ damage, either in the emergency department or an observational hospital setting. It's important to note that the hypertension-related organ damage can be progressive. It can progress at the point you're seeing the patient, maybe is not really showing signs or features of that. That is why it's good to also admit in certain instances and monitor, patients' progress before sending them home. All right.
Okay, so for emergency, this is our target blood pressure control. So when you're dealing with hypertensive emergency, emphasis on there's end organ damage. Then for the first hour, we talked about 25% reduction in your blood pressure, mean arterial pressure by 25%. Then the next 6 hours, the blood pressure should be down to about 160. And then subsequently in the next 24 hours, we should get the blood pressure within the normal range. So gradual reduction in emergency. So ideal drugs for emergencies have rapid onset, they're short acting because we just wanted to bring down the blood pressure. We don't want it to crash it so that we can control the medications, So we want it short acting and it gives room for other medications to kick in because you're starting off with IV. Emphasis on emergencies, it must be IV medications first. And then subsequently, you can now continue with your orals. So we are talking of IV in emergencies, ICU care, monitored closely, blood pressure reduced gradually, mean arterial pressure reduction of 25% in the first hour. Subsequently, in the next 6 hours, systolic about 160, and then in the next 24 to 48 hours, the blood pressure should be relatively within the normal range for the emergencies. So treatment of hypertensive emergency always warrants hospital admission. So we've said it over and over. Once you're dealing with an emergency, this patient should be admitted, preferably in the ICU, and the patient must have IV antihypertensives, because what we want that blood pressure to be removed, to be brought down as soon as possible, but gradually. And some of these IV antihypertensive medications that are available, readily available, is labetalol. And the good thing about it is that apart from giving it as a bolus, we can also give it as an infusion. And the good thing about the infusion is that it can be given in such a way that we can titrate and monitor it, so as to know when to stop if we're getting to our target, or increase if we need to. Their use often necessitates continuous blood pressure monitoring. So that's why we said this person should be in the ICU, because that's where that can occur. You know, the person is connected to the cardiac monitor, continuous blood pressure monitoring, preferably via arterial line, but if you can't do that, just the usual cuff connected to the cardiac monitor is good. In hypertensive emergency, the purpose of treatment is to preserve the brain, kidney, and heart function. So we've said it, there's end organ damage and we want to halt that. So the whole idea is to bring down that blood pressure to reduce further damage. So before we go into the detailed section or talk about this detailed aspect of hypertensive emergency, it'd be good we hear from the public relations team on what cardiac care is all about, so that you know that yes, you can refer your patients to us after you've done your initial blood pressure reduction. Or before we go into that, let's continue for now. At some point, we'll talk about what we're all about, cardiac care. I'm sure a lot of you know what cardiac care, what specialty hospital is all about, but we'll go into details later on. Let's continue for now, please. So talking about hypertensive encephalopathy, we said that it's important to differentiate it from a stroke because the symptoms might be similar. So we need to do a quick history and immediately request for a CT if in doubt, because this patient would present with abrupt change in mental status. And all this is because of the acute end organ damage that has occurred, the elevated blood pressure causing failure of cerebral autoregulation occurs, there's endothelial damage, arterial dilatation resulting to hyperperfusion of the brain, resulting to edema, microhemorrhages formed, you know, and then preferably, we said with these patients we need IV medications, preferably labetalol, which is readily available. So for patients like this, they might come in confused, headaches, you know, irrational, but they will not have hemiparesis, because once you're seeing somebody with hemiparesis or slurred speech or facial nerve palsy, already you're thinking, oh, possibly there's a stroke here. But if they're just irrational, confused, elevated blood pressure, but of course in doubt, get a brain CT to ensure that you can differentiate it from a stroke. Encephalopathy is an emergency IV antihypertensive. We try to avoid central acting antihypertensives in any CNS presentation because of it can cause CNS depression. So we don't want to give clonidine, methyl dopa, recipe, because methyl dopa is readily available. People are always quick to give it, you know, and then it can act almost immediately. You know, it acts really good. They give it, brings down the blood pressure. Everybody seems to be okay, but rather you've worsened the neurological deficits, you know. So, and then adrenaline, we know that yes, adrenaline is also readily available, but we should be careful with adrenaline because of the risk of increase in intracranial pressure. So the preferred medication is the labetalol because that is readily available. I don't know if anybody has nicardipine available in Nigeria, but if you have access to it, that's good. But labetalol, we know that is readily available and we can give it. Then the other emergency we want to talk about is myocardial infarction. So, from our history, it should help us know what we're dealing with. By the time the person comes with chest pain, worse on exertion, having diaphoresis, relieve that rest, there's palpitations, then you are already considering, could you be dealing with a myocardial infarction? So, there's increased workload to the heart, there's activation of the RAS system, but the treatment is aimed at increasing blood flow to the myocardium and reducing the workload to the heart. So at this point in time, the antihypertensive we want to give will be that can help to increase coronary blood flow, while we're prepping up the patient for either a percutaneous coronary intervention. So our standard treatments for someone presenting with myocardial infarction, remember we've done our investigations, went into details with our investigations. So you've confirmed this person has myocardial infarction based on the ECG findings. It could be STEMI or N-STEMI depending. And then there's elevated troponin. So we've sorted that out with our investigations. So now we've confirmed there's myocardial infarction, preferred medication with elevated blood pressure, because sometimes they can come in hypotension. So those with hypertension, you're not even talking of antihypertensive or anything to bring down the blood pressure. But those that come with markedly elevated blood pressure, the preferred drug would now be your IV nitroglycerin or your IV beta blockers to bring down that blood pressure. And our target systolic blood pressure would be target systolic blood pressure is to reduce until symptoms subside or diastolic less than 100. You can give morphine or oxygen if the SpO2 is less than 94%, you give oxygen. Morphine also helps because it helps reduce the sympathetic overdrive that comes up with the anxiety, the chest pain, so it also helps when you're able to reduce the sympathetic overdrive and then calms the patient and also reduces the pain. So, morphine is helping in different ways. So yes, morphine also can be given.
And then IV nitroglycerin, we should also know why we're giving that.
Yes.
It's vasodilatory effect on the heart. It helps with perfusion as well to the already ischemic and oxygen-starved myocardium. Then the beta blockers, we know it reduces the contractility and the workload of the heart and then improves oxygen supply to the heart as well. So it's important to know at least an idea of why we are giving any of this medication.
And the good thing with the IV nitroglycerin is that we also have the sprays, so that can easily be given under the tongue, so we do that a lot. The spray NTGs, especially with elevated blood pressure and in the setting of myocardial infarction. So we also consider thrombolytics, especially if the person is within the window period and cannot do a percutaneous coronary intervention. But we should also remember that we don't want elevated blood pressure when we want to give thrombolytics. So heparin infusion should not be started with an uncontrolled systolic blood pressure because it would cause, it increases the risk of bleed. So rather, you want that blood pressure to come down if you're considering thrombolytics in the setting of myocardial infarction. So in heart failure, in the setting of heart failure, we also need to remember that these patients can also come in pulmonary edema. They might be very dyspneic, have autopnea, PND, acute onset difficulty in breathing. They are so breathless, blood pressure markedly elevated, So already you're thinking of an acute pulmonary edema. And sometimes this patient might even have a background heart failure, or that might just be the first time you're making that diagnosis, So, and then the patients at risk of these are most often the older people, those with long-standing hypertension, diabetes, they have not had their blood pressure well controlled, and now they're coming down in heart failure or pulmonary edema. And here, the left ventricle initially attempts to compensate for the rising blood pressure because there's elevated blood pressure that has been persistent, and the heart is trying to cope with it. But subsequently, that doesn't happen anymore. The myocardium needs more oxygen, there's dilatation, there's increased pressure in the left ventricles, causing backflow of blood into the lungs, So the whole idea is the focus is you want to try and reduce the preload, the afterload, you want to improve myocardial contractility and reduce the peripheral vascular resistance. So in cases like this, when you're dealing with pulmonary edema or acute heart failure, the choice of antihypertensive is that of either IV you want to give IV nitroglycerin. You can also give your other heart failure medications. But in this case, we talk so much about labetalol, but we need to remember in the setting of acute pulmonary edema, no and no and no IV labetalol.
No to IV labetalol.
No to IV labetalol. We say no to beta blockers in the setting of heart failure or pulmonary edema because at the end of the day, what do? They have a negative inotropic effect. They rather slow down the heart. You're slowing down the heart when the heart is having increased contractility as a method of compensation, So you're now going against that compensatory mechanism. You're slowing down the heart, you're increasing the pressure in the ventricles, and you're going to worsen the pulmonary edema. So the patient is going to get worse. So it's not just the blood pressure that are now reducing, you're worsening the patient's condition. So that's why we keep saying, it's not just the numbers. The patient, what does this patient have? So that you will know what medications to give to. Because what you will give to A's blood pressure is not what you give to B's blood pressure, depending on the presentation. So somebody coming with crepitations, difficulty in breathing, high index of suspicion of heart failure, because heart failure, we know it's a clinical diagnosis. Having symptoms of heart failure, coughing, frottis sputum, leg swelling. At times, they might not even have leg swelling if it's just pulmonary edema, Autopnea, PND, they are dyspneic, you listen to the chest, widespread crepitations. Please, no labetalol. We keep saying it, no labetalol, no beta blockers, because you're going to worsen that patient's condition. Rather, you go for something else. We have our IV nitroglycerin. You can even give diuretics. Yes, we do our diuretics also. If you don't have your IV nitroglycerin, we have it readily available here. We use it very well, very often. But some places might not have it readily available. You have your diuretics, you have your torsemide, you have your furosemide IV. You can give that to help decongest the lungs. And then, of course, ensure that you do your normal guideline-directed medical therapy for those in heart failure. And then we keep saying, treat the patient as a whole. With your investigations, there are other things you might want to address, both the etiology of the heart failure and the precipitants. So the acutely elevated blood pressure causes left ventricular afterload mismatch, left ventricular end diastolic pressure rise. This we've all talked about. Increased pulmonary venous pressure. There's leak and transcapillary leak, and this is what causes the pulmonary edema.
So for patients with prior euvolemia, may not need to get loop diuretics like your furosemide, because the pulmonary edema is not due to a maldistribution of the intravascular volume, and it's not due to total body volume overload. The fluid is just there in the lungs, so you need to target that. So intravenous loop diuretics may have an initial beneficial vasodilatory effect, but the subsequent volume depletion can cause future hemodynamic side effects. Thus, treatment should be aimed at decreasing the acute pressure overload and afterload mismatch, which will reverse the fluid shift in a time frame similar to the rate of the compensation. So in this instance, it's good to give a preload reducer, like the IV nitroglycerin, an afterload reducer like the AC inhibitors or ARBs before then you can now give your loop diuretic if need be. So we should be careful about just giving loop diuretics, especially in those cases of flash pulmonary edema when there's no generalized edema, is just in the lungs.
Because the caveat there is a prior euvolemic patient.
Yes.
But of course, if you're not sure this person, you're just seeing the person for the first time, there is widespread crepitations, you have your high suspicion, excuse me, of pulmonary edema, then please, if you don't have your IV nitroglycerin, you can go ahead with your loop diuretics.
Yeah. And then beta blockers and calcium channel blockers must be avoided in the decompensated state. We've already said that, they have negative chronotropic and inotropic effect, which will now worsen the state the patient is in already. So this will cause increased left ventricular filling pressure, backflow of blood to the lungs, and then keep on precipitating the pulmonary edema. So for aortic dissection, this is a true medical emergency that can result in significant morbidity, and mortality. We have two types. We have the type A dissection that occurs proximally at the ascending aorta. We have the type B dissection that occurs at the level of the descending aorta. So typically, we know that type B is managed medically. As surgical treatment carries a very significant risk because it affects the descending aorta. However, for the ascending aorta, you can also, sorry. So typically type B dissection is managed medically because surgical treatment carries a significant risk. But for type A, you can manage it surgically. So both types of aortic dissection are strongly associated with uncontrolled hypertension. So you see why uncontrolled hypertension is a very, 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 big issue if not well controlled. That is why we've been talking about the education, making sure that the patient is on the right medication and is what's it called, is well monitored long term, not just in the short term. If you control the BP today, but what happens next month? What happens 1 year, 2 years later? So there should be continuity in care of this patient. Then in some patients, it may be precipitated by an acute hypertensive event. Now, the goal for blood pressure reduction is to decrease the shearing forces associated with the dissection. And this is accomplished by lowering both blood pressure and pulse rate. So you want to target the blood pressure into bring it down as much as possible. You want to also target the pulse rate as well. So while type A dissection are usually managed surgically, all affected patients will require some component of medical management and tight blood pressure control. So here we are not scared of bringing down the blood pressure because the current recommendation for blood pressure in aortic dissection is swift, fast downward titration of a goal of systolic of 100 to 110 millimeters of mercury and a heart rate of 50 to 60 beats per mercury. So that is the goal in aortic dissection. So a beta blocker in combination with a vasodilator administered intravenously should be used for swift blood pressure reduction. IV intravenous nitroprusside is a potent vasodilator. However, it can lead to cyanide poisoning because it's metabolized to cyanide, and it can lead to leather toxicity, especially in patients with hepatic or renal impairment. Now, in this patient population, you can go for intravenous labetalol or esmolol. Have you seen esmolol?
No, okay. Not in IV.
So we stick to intravenous labetalol.
Readily available.
Yes, it's readily available. So that is what you most certainly will use. And then suspect hemopericardium with tamponade or aortic rupture if hypertension is present prior to initiating therapy. As before you giving your antihypertensive, patient is already hypertensive. You need to think of tamponade or hemopericardium.
So, please, before we continue, we would want to talk more about Cardiocare Multispecialty Hospital. So, we want to tell you all about Cardiocare Multispecialty Hospital. We want to encourage you to refer your patients if you're having issues managing, and we are always readily available to sort out whatever issues.
Yes.
We have our numbers you can reach.
No need to go abroad, right?
Yes, no need to go abroad. We have it here, available, competent hands.
Yes.
We have all the facility, the devices, the everything you need concerning cardiology care. We'll go into details shortly.
Okay, my name is James Emmanuel. I'm the public relations manager of the Limi Hospitals. So thank you all for joining in. I'll be telling us about Cardiologist Hospital and how to refer patients to Cardiologist. So who we are, Cardiologist Hospital is located at number 5 Abuja. We are 90 minutes away from any part of. So cardiac care. So our focus research. We do local training and exposure of medical professionals, and one of our you don't need to travel outside the country to get. We have able hands and we have people that have been trained to do that here at Cardio Care. So Cardio Care is a fully dedicated comprehensive cardiovascular and internal medicine hospital. We have received awards for a support hospital for your practice in Nigeria through our specialized services, training, research, and collaborations. So, Cardio Care, here we do here at Cardio Care, we do interventionology, nephrology, transplant and dialysis, neurology, rheumatology, and so many more. So we give what makes Cardio Care different from us. We give detailed back referrals. When you refer to Cardio Care, we then back with a detailed back referral so that you can have the opportunity to also discuss and collaborate with your team on the cases. When we have cath cases, you can fly in with your team or can join our team to conduct the case also. We have 24/7 emergencies and same day, next day appointment cath cases for pacemakers, CRTs, coronary and peripheral revascularization with stents, IVC filters, and etc. etc. So if you want to refer your patients to us, as you can watch on your screen, as you're watching on your screen, here are the numbers that you can reach us on. You can call the number that is displayed on your screen. You can call us on 090-8331-777, 081-7444-088. You can also send us an email to frontdesk@cardiocare.ng because here in Abuja. We also have so I've pasted the link that's on the question and answer page. So you can just join the WhatsApp group so that you can get information about our webinar twice a month, second week of each month and the fourth week of each month. Thank you so much for joining in, and we hope to hear from you soon. Thank you so much, and as I hand over to our doctors, continue. Thank you so much. Yes, I can see the screen.
We're not back yet. We're still on the manual. Okay, so we're back on to continue the presentation on hypertensive crisis, talking about hypertensive urgency and emergency. So we're still on emergency. Now we're talking about acute renal failure. So this guest has now, or this patient now is presented with symptoms that suggest renal failure, either reduced urine output, there is hematuria, creatinine is elevated blood pressure. Already you're thinking of an acute renal failure. So in an acute hypertensive episode, it is often difficult to determine whether an acute renal failure is the cause or the effect, you know. So you're not sure, is it just the renal failure that's causing elevated blood pressure, or is the elevated blood pressure now that's causing the renal failure? Or regardless of whatever it is, this patient has acute renal failure. So rapid reduction in blood pressure is warranted to preserve the renal function and to stop the cycle of microvascular kidney destruction. So blood pressure goals are aligned with the general treatment of recommendation. As we said in emergency, we want to bring down that blood pressure as soon as possible. We said mean arterial blood pressure of 25% in the first hour. In the next 8 hours, the blood pressure should be about systolic of 160, and then the next 24 hours, it should be within the normal range, while you're sorting out other things this patient might need, in the sense that if this patient also need other care, like if the patient will benefit from dialysis, fine, we can go ahead with that, you know, but the blood pressure needs to be reduced. Also, the preferred antihypertensive is either we use IV phenoldopa, a dopamine receptor agonist, or we can use a calcium channel blocker. So whichever one you have available, the whole idea is we need to bring down this blood pressure as soon as possible. In the setting of...
Okay, so now we talk about stroke. This is also a very common emergency that will come across one way or the other. So elevated blood pressure is common, especially in the early stages of stroke. And there are several studies that have analyzed the outcome in patients that presented with ischemic stroke and uncontrolled hypertension. So evidence has shown that there's usually poorer prognosis in patients treated aggressively with antihypertensive agents. Please, let's not be too overzealous in bringing down the blood pressure, especially in the setting of stroke. Very, very important. We'll know why this is important as we go along. So the association between dramatic reduction in blood pressure and poor prognosis, it lies in the theory of what we call the ischemic penumbra. This is an area around the core. The core is a core ischemic tissue that is already compromised due to lack of blood supply to that particular area in the brain. So because of this, enough blood does not get to that particular region to maintain neuronal activity, and then it results in injury. And this penumbra area is susceptible to further infarction. Now, once you drop the blood pressure, overzealously drop the blood pressure, you have compromised cerebral blood flow to collateral vessels that would have helped to perfuse that area that is already at risk. So precipitous drop in blood pressure So precipitous drop in blood pressure can reduce blood flow to collateral blood vessels, cerebral vessels, and it can result in hypoperfusion of the penumbra, and this will lead to further neurologic damage. Once you've dropped that blood pressure, especially in the setting of ischemic stroke, you're just going to worsen the patient's clinical outcome, and the prognosis, I assure you, is usually very, very poor. Uncontrolled hypertension is often associated with what we call intracerebral hemorrhage. Is a risk factor, or even can be considered a factor that contributes to this event. So once a patient has experienced an acute brain insult, the blood pressure can become even more uncontrolled. Remember, we spoke about the autoregulatory center. Once that autoregulation is lost, that blood pressure can actually get more and more uncontrolled. You see blood pressure at presentation is 160, 100, before you know it is up to 190, and then you panic and then crash the blood pressure. So extension of the hematoma and the worsening outcome are the main concerns in treating the patient with concomitant blood pressure elevation and intracerebral hemorrhage. Also of concern is maintaining adequate perfusion. So you want to strike a balance in bringing out the blood pressure as well as maintaining adequate perfusion to that penumbra. Now, transient hypoperfusion can develop when the intracerebral pressure, intracranial pressure is elevated and the mean arterial pressure is acutely lowered. This will reduce the cerebral perfusion pressure. We have the formula, which is cerebral perfusion pressure is equals to mean arterial pressure minus intracranial pressure. And we know that cerebral blood flow is equals to cerebral perfusion pressure divided by intracranial resistance. Is similar to that of blood pressure and cardiac output. So when you aggressively treat systolic blood pressure, what happens is that you're going to worsen the penumbral perfusion. So aggressive treatment, if systolic blood pressure exceeds 200 milliliters of mercury or mean arterial pressure exceeds 150, it's advised. But if not, it's best to be watchful. But then, like I said, you have to individualize treatment of the patient. So a treatment goal to consider is reducing systolic blood pressure to 160 or MAP of 130 millimeters of mercury. Now, patients with elevated intracranial pressure should undergo placement of a ventriculostomy to maintain a cerebral perfusion pressure between 60 and 80. That's the target. We've had a lot of cases in our ICU where we've actually carried out this procedure, the ventriculostomy, and yeah, there have been some success stories as well. So although the risk for infection or intracerebral hemorrhage must be weighed against the potential benefits. So it's not every patient that you take to theater to carry out this procedure. You need to weigh the benefit against the risk. When the prognosis is so poor, you might not really want to go ahead to carry out this procedure. Then when blood pressure reduction is required, the mean arterial pressure should not be lowered more than 20% in a 24-hour period. Now, we have some recommended agents. They are the popular IV labetalol, which is always readily available. We can also do IV nicardipine, IV enalapril if it's available, IV esmolol, IV hydralazine may be in some cases, even though it can lead to raised intracranial pressure. For acute ischemic stroke, optimal control of blood pressure during management of acute ischemic stroke is imperative to reduce morbidity and mortality. Stroke comes with a lot of morbidity and mortality, especially in this part of the world where access to quality healthcare is lacking. We're in Abuja. Most of us in other areas are not privileged to have access to quality, healthcare. So it comes with a lot of morbidity and mortality, because of so many other factors, finance, socioeconomic status and all that. So areas affected by edematous brain tissue are at increased risk for bleeding. It can lead to what we call hemorrhagic expansion. And then careful history taken to elicit their average blood pressure range is also very important. It will help you to determine the goal pressures during management of the acute stroke phase so that you can actually individualize and know your target blood pressure. But some things are sacrosanct. If planned for thrombolysis, you need to aim for a systolic of less than 180 and there's diastolic blood pressure of less than 105 millimeters of mercury. But if no thrombolysis, leave the blood pressure alone. except the blood pressure is above 220 over 110 millimeters of mercury. Remember, you want to allow for permissive hypertension to keep that area, the penumbra, like we mentioned, quite perfused. So always treat the patient and not the numbers. Don't panic and crash this blood pressure and worsen the patient's outcome. And then if blood pressure reduction is needed for other medical conditions, for instance, patients that have also decompensated heart failure, blood pressure should not be lowered more than 10 to 15% in a 24-hour period. So it's very, very important that this patient is managed ideally in an ICU or HDU. If you cannot manage this patient in an ICU, like we all know, this is a hypertensive emergency. Ideally, that's the setting to manage this sort of patient, but we can improvise. I mean, we're in sub-Saharan Africa, West Africa to be exact. So we can actually improvise and make sure that we have the necessary tools to monitor the patient, like a cardiac monitor or regular monitoring of this patient. So no specific antihypertensives are preferred in patients with acute ischemic stroke. You can use the esmolol, you can use IV enalapril, you can use IV labetalol, or nicardipine can also be used.
So the two complications of subarachnoid hemorrhage that must contribute to morbidity and mortality is bleeding and vasospasms. So in this case, because of course, our brain CT already helps to differentiate what type of stroke we're dealing with. This patient presents with symptoms that suggest stroke. The history and then the brain CT now confirms what type of stroke. Are you dealing with an intracerebral hemorrhage? We are dealing with ischemic stroke, or you're dealing with a subarachnoid hemorrhage. So already we've talked about hemorrhagic stroke and ischemic stroke. And in summary, all we've said is for hemorrhagic stroke, we need our blood pressure to come down within within 24 hours for hemorrhagic stroke. For ischemic stroke, that blood pressure should remain, that's what we call permissive hypertension, for at least another 48 hours. Except the blood pressure is above 220 over 120, then you can gradually just reduce it a bit. But we want to preserve that penumbra region that is in the ischemic stroke. That is why we are not too aggressive with the blood pressure initially, but subsequently we can now place on antihypertensive. But for hemorrhagic stroke, yes, you can start your antihypertensive from that first day of presentation and gradually reduce within 24 hours. So your hemorrhagic stroke follows that pattern, just like our normal hypertensive emergency. But for your ischemic stroke, you might allow hypertension for a while. That's a permissive hypertension for at least about 48 hours. Some will say 24 hours, 24, 48 hours. Roughly, we just say stay safe 48 hours. Except, again, as I said, except that blood pressure is very high. If you're dealing with something, someone comes with ischemic stroke, the blood pressure is higher than 220, 120, then you want to reduce it a bit. And our choice of antihypertensive, as we said, IV labetalol is good because you can monitor that blood pressure reduction. And then subsequently, you can now add the oral medications, because the oral medications will take a while to kick in, but the IV would bring it down almost immediately. At least you see some reduction. And then subsequently the orals will kick in and then maintain the blood pressure reduction gradually as you also sort out all the presentations the person would come in with. That means if the person has cerebral edema, of course, you want to do your mannitol and all the rest. But for the blood pressure control, this is what we're talking about now. So if you are dealing with subarachnoid hemorrhage, of course, your CT scan will also tell you this is subarachnoid hemorrhage. This is another case where you need to bring that blood pressure as soon as possible, because this can cause, with this high pressure, there can be rebleeding and vasospasm. So blood pressure control with subarachnoid hemorrhage is imperative because it can contribute to worsening the outcome. This is just a table showing us the different, just like a summary of the different conditions we've talked about, the hypertensive emergencies and the medications we can use. We can roughly say that labetalol has been mentioned over and over. So that seems to be the safest we can use, IV labetalol in hypertensive emergency, except in pulmonary edema and acute heart failure. Every other conditions we've mentioned, we can easily use our IV labetalol because it's readily available. You can monitor it because apart from it giving it as a start dose, you can give it as an infusion over time and stop or increase. So you have good control of it, and it's short acting. So if you want it off the system on time, you can just stop, and before you know what's happening, you've achieved whatever blood pressure goal you want, and you can then maintain with any of your oral antihypertensives. So you will all get the slides later on, but this is just a table summarizing all that we've said. This also explains every other thing we've said, the different conditions and the medications we can use and what to look out for. What else again? So these are some of the medications we've talked about, their onset of action. You can see labetalol within 5 to 10 minutes, it's there. It's already bringing down the blood pressure. Within 8 hours, you know, we are sure that we have good blood pressure control depending on what dose you're giving. We've listed out all the indications, but we said it over and over. No beta blockers, no labetalol in the setting of pulmonary edema or heart failure. And then, of course, we should be careful with our beta blockers if you're dealing with somebody that has bradycardia. So that's why we keep saying the individual, the patient, not just the numbers. We won't say because they said, oh, give IV labetalol, somebody's presenting with bradycardia, you would now give, you have to think of an alternative that is readily available that would not affect the pulse. So this is just a summary of all that we've mentioned, the different conditions, and then the dosing.
So for prevention of hypertensive crisis, we've said a lot, we've said a lot in the past over an hour now about the different, the definitions. We've talked about the two types, the hypertensive emergency and hypertensive urgency. Now, this presentation will not be complete without talking about prevention. Prevention is key. Primary prevention, health education, very, very important. Every patient at risk of hypertension, Black, male, pregnant, women, every patient at risk of hypertension should have health education concerning primary prevention. Talk about lifestyle modification, exercise, increased physical activity, 30 minutes per session, at least 5 times a week, having at least 150 minutes of physical activity, exercise every week. Talk about diet, dietary modification, ensure whole-based, plant-based diet, talk about smoking cessation, things that can put patients at risk. Don't wait till they develop hypertension. Make sure that you educate your patients health-wise. Then blood pressure monitoring. Every adult should have at least annual blood pressure monitoring done. And for those who have a family history of hypertension, they should have closer monitoring of their blood pressure and should be made aware. It's not just for old people. Anybody can have high blood pressure. And then lifestyle modification, like I said before. Then secondary prevention is talking about early identification, early detection, and then treatment. So when the patient has come to your clinic, assuming the patient comes with symptoms of malaria, doctor, I think I have malaria. You know that hypertension in most cases is asymptomatic, above 90% of the time. So when you've checked the blood pressure, you've identified early enough that this patient is hypertensive, you've examined, you've taken a good history, you've examined, you've carried out appropriate investigations, ECG and echo. Echo is very important. Echocardiography is very important to be carried out for every patient, irrespective of age or gender, who has been diagnosed hypertensive should have a baseline echocardiography done, and then manage the patient accordingly, according to the guidelines of management of hypertension to prevent complications. Why am I stressing this? We want to prevent complications because hypertensive crisis is the complications of poorly controlled blood pressure, uncontrolled blood pressure. That is what leads to hypertensive crisis. Then tertiary prevention is those that have had this issue. Probably they've developed complications, heart failure, stroke, kidney failure, and all that. Rehabilitation is also very important. You also keep, talking to them about educating them appropriately on adherence to medication and regular clinic visits. So those are the pointers on prevention. And then remember that when you're managing your patients, you should manage holistically. Don't just manage in isolation. looking at the blood pressure without looking at the person, individualize treatment and make sure that they are managed holistically.
So going through the last case for today, we initially had 2 questions. Maybe we should go through those 2 questions first of all, based on what we now know, before we talk about the 3rd case. The first question was, sorry, please, just a minute. First question was, how do we differentiate urgency from emergency? And a lot of people got the right answer. They said yes, it's C.
Yes.
It's the acute organ damage. So we said this over and over. Why we are trying to explain the difference is because the mode of management is different. Urgency, no end organ damage. Emergency, there's end organ damage. We've gone through the different types of end organ damage. We're talking about heart failure or pulmonary edema, stroke. Stroke we talked about, ischemic, hemorrhagic, subarachnoid hemorrhage. Then we talk of renal failure, and then we also mentioned hypertensive encephalopathy. So we're dealing with end organ damage in emergency. And then the answer to this question, with someone that came with markedly elevated blood pressure, no symptoms, every other thing normal, just elevated blood pressure. Somebody got the answer and said hypertensive urgency. So that's what it is, hypertensive urgency. And just to answer another person's question here that said, okay, can we just give a summary of the treatment? Who said it, to differentiate urgency from emergency, there's end organ damage. So if you're dealing with urgency, we know that there is no need to crash or urgently bring down that blood pressure. You're bringing down the blood pressure can be done within 24 to 48 hours. So any of your antihypertensives can be used, preferably those that are short acting, so that they can quickly bring down that blood pressure within 24, 48 hours, and then you can continue with your oral long-acting medication. So that's why we talked about you can use your labetalol, you can use your nifedipine, all those medications will quickly bring down that blood pressure. But subsequently, you need to continue, that's for those with markedly elevated blood pressure. We're not talking about normal hypertensive with just elevated blood pressure. We're talking about hypertensive crisis that come in urgency, markedly elevated blood pressure. You want to quickly bring it down and then continue with other oral antihypertensive, your ACE inhibitors, your ARBs, your calcium channel, your beta blockers. You can continue with all of that, But your aim is to bring down that blood pressure within 24 to 48 hours, no rush.
And that's why you give a short appointment.
Yes, we talked about that. That's not someone you're going to see in a month's time. You're seeing the person either the next day, 2 days. You're trying to even just keep the person in the hospital, just to be sure that you can actually monitor that blood pressure reduction appropriately.
Yes.
So going back to the 3rd case, then for emergency, we've talked about emergency and we've listed all the causes of the commonest causes of hypertensive emergency. And we said with that, the blood pressure reduction we said the first hour, 25% of mean arterial pressure. The next 6 hours, we said systolic blood pressure should be about 160. And then in the next 24 hours, the blood pressure should be within the normal range, So let's go back to the last case. So somebody presented here in cardio care. So our cases are life cases. A 66-year-old woman, known heart failure with reduced ejection fraction, presented with, and also diabetic, presented to an emergency with difficulty in breathing of 1-day duration, autopnea, PND, cough. There was no leg swelling, there was easy fatigability. The patient has been on medications, but the drugs got finished. I know all this story of, my appointment was supposed to be on Monday. My drugs finished on Friday. I started to wait till Monday, That's why we keep saying education, education, education. If they know that, my appointment is on Monday, I can come to the hospital on Friday to refill, They should have come to the hospital, but sometimes they wait and just feel like, my blood pressure is normal now. Not knowing that just 1 day of not taking, missing 1 dose is a problem, that BP that is normal can go up and then cause problems, you know. So that's how this patient came in with difficulty in breathing, pulse rate 105, blood pressure 185/96, JVP was not elevated, apex beat 6 left intercostal space, heart sounds 123. There was a pansystolic murmur, respiratory rate 32 cycles, SpO2 was reduced. There were crepitations in the mid and lower lungs. So please, what do you think this diagnosis is based on all what we've been saying for over 90 minutes? I'm sure everybody, I'm sure it's going to be 100%. So please, can we just put in, what do we think? A, B, C, D, E? What are we dealing with?
Is it pulmonary embolism? Is it hypertensive urgency? Is it C, uncontrolled hypertension? Is it D, acute pulmonary edema? Or is it E, aortic dissection? What's your answers? Let's put them up in chat box.
We're still waiting. Response. Okay, some response have started coming in.
Yes. Okay.
Okay. You can see D, 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 D. Oh, beautiful.
So that's 100% pass.
We are happy. At least we know that, yes, the message has been passed across.
Yes, we paid attention. That's good. So we can save lives.
Exactly.
You know,
and then, please,
and
can
hospitals, we can save lives.
So please, can someone just, it's not there, but can someone just quickly put what choice of medications would we give? What won't we give?
Which medication won't we give? Must you not give?
Yes,
so,
not give.
Yes. So can someone put it up in the chat box? What must you not give to a patient with acute pulmonary edema?
Thank you. That's
very good. Very good.
Okay.
Very good.
So we are happy.
Yes.
But we can use our diuretics, our torsemide, our furosemide.
Yeah.
We can use our IV nitroglycerin.
ACE inhibitors.
You can do all that.
Yes.
You know? Okay.
So in summary, after this stimulating presentation, we all know that hypertensive urgency and emergency need expeditious evaluation to avoid the significant morbidity and mortality. You know that hypertension is one of the leading causes of mortality and morbidity in this part of the world, especially in low and middle income countries like ours. So let us all play a little role or major role or part in reducing the significant scourge. So hypertensive urgency is defined as a diastolic blood pressure of greater than 120 millimeters of mercury without evidence of end organ damage. But I will stress once more that these figures are mostly arbitrary. So you really need to individualize patient care based on evidence of target end organ damage or not. So hypertensive emergency in which acute end organ damage is present, lowering blood pressure should be directed by the type of end organ damage and or underlying comorbidities. Remember, just like in acute pulmonary edema, you do not give IV labetalol. IV labetalol is also a choice, you know, of medication in several other types of hypertensive emergency. So in general, blood pressure should not be lowered more than 10% to 25% within the first hour, with normalization achieved over the next 8 to 24 hours, especially in hypertensive urgency. In cases of acute ischemic stroke, permissive hypertension is recommended. Do not crash the blood pressure. Do not crash the blood pressure. If the patient has, maybe you feel the patient has features of raised intracranial pressure, give your monitor. Exactly. Follow it up with IV furosemide, but don't give any antihypertensive. The penumbra is at stake. Let's save the penumbra, right?
Yes.
So above all, treat patients, not numbers. Bearing in mind the Hippocratic oath, first do no harm.
And as usual, refer if you're not sure what next to do, or you've started something, you don't know what, or you can't complete it, please refer. And always see the patient as a whole. It's not just the high blood pressure. They might have other comorbidities. That's why we went extensively into investigations, because other things could be there, diabetes, you know, hyperlipidemia. They could have kidney issues that needs to be addressed, you know, heart failure, you need to place on other medications. Just that our focus was just on the elevated blood pressure, but other parameters must be addressed also alongside the high blood pressure.
So in summary, holistic care at all times. Treat your patients holistically, manage them holistically, and not in isolation. Thank you very much.
Okay, we can see a question on the IV nitroglycerin. We've said that we'll give you the slides. There's a chart on how to give it, because it's titrated. So you have to titrate it properly and then know how to bring it down with your with respect to the blood pressure. So you would get the slides on that, because there's a way it's been titrated. You have to calculate it and titrate appropriately.
Then someone asks about the safest maximum tolerable dose of commonly prescribed antihypertensive, especially in view of resistant hypertension. Well, when patients are already on three medications, three antihypertensive medications, and blood pressure is still not well controlled, that is resistant hypertension as it is. So you need to optimize the antihypertensive the patient is on.
So for resistant hypertension, we always talk about 3 different classes of hypertensive medications with a diuretic at maximum tolerable doses. Because what might be tolerable to one might not be tolerable to another. Maximum tolerable doses. Then you should consider it being a resistant hypertension, and then there'll be need to have a spironolactone 25 to 50 milligram, and then any other antihypertensive. You have your alpha blockers, you have your beta blockers, they can come into play. So if you say, for example, the person is on valsartan, maximum dose of valsartan is 320, you're on valsartan, and that's tolerable, because some people, by the time they're reaching 320, they might have some complaints. So whatever is tolerable for that patient is its maximum dose for that person. You know, but you don't exceed the 320 for valsartan. Every drug has their different. So when you say maximum dose of ACE ARBs, is a long list. So every drug has what is maximum. For telmisartan, you know, you're not going beyond 80. You know, so every drug has their maximum. If you're talking of amlodipine, you know, you can't go beyond 10. You know, things like that. So there's a lot. They all have their maximum doses. So person is on, let me say valsartan 160, and that's tolerable at that level. Amlodipine 10, tolerable at that level. And on hydrochlorothiazide, maybe it's on 12.5, and that's what's and still, this patient is still having elevated blood pressure, not well controlled, and the person is regular on medications. BP is properly checked, because you need to rule out pseudo-resistant hypertension, because there are some people that BP is not properly checked, or there's something that is causing the elevated blood pressure that needs to be ruled out. You know, let's be sure that person is taking the drugs appropriately. Then there's room to add spironolactone 25 to 50 milligram daily, and other medications. You have your alpha blockade, that's your doxycycline, you have your beta blockers. There's a long list of beta blockers, from your what's it called? From your metoprolol, succinate, to carvedilol, to bisoprolol. You have a long list there. So those are other options. And then, of course, the central acting ones, like what's it called? Aldomet, yes, methyl-dopa, that can come into play too. Once you've exhausted those that are maximum, those that have benefits to the heart. So basically that. You said a 66-year-old man with BP of 240 over 120 with moderate headache. I don't know what moderate headache is.
Headache is headache.
Headache is headache, yes. No visual or other neurological symptoms. So now the question now is what, as in how do you classify that headache? Because when you talk of headache is a whole topic on its own. Because there are other questions you want to ask this person to know what type of headache you're dealing with. You know, is it headache that is suggestive of a migraine, or is it headache that is suggestive of a subarachnoid hemorrhage? You know, or is it just a headache that is from stress? You know, you need to, is it tension head? You need to there are so many questions you need to ask about this headache to know what you're dealing with. But we keep saying when in doubt and you're suspecting a neurological issue, especially with the brain, just do a brain CT so that you are sure of what you're dealing with, you know. And then if the brain CT is clean, at least you know the stroke is out of it, you know. If the brain CT is not clean, then you address it based on what you're seeing. Is it hemorrhagic or ischemic? But if all of that is clear, no symptoms, nothing else, then you know you're dealing with hypertensive urgency. Then there's no problem. Just, we said it already, give your antihypertensive, start with those ones that are short acting like labetalol to bring it down on time. But our target is between 24 to 48 hours, you're not crashing it, you know. And then investigate this patient because something else might be going on. Is this a newly diagnosed person or somebody that is a known hypertensive, or are there other issues? What are the examination findings? Is the chest clear? Are there signs of heart failure? You know, you need to be sure all of that is out of the way. Renal failure, you know, so exactly. Especially when you're seeing a markedly elevated blood pressure, you need to be sure that the kidneys are good too. So that if they are not, you can address it. So as we said, you're treating the patient as a whole. So you need to address other comorbidities that this patient might possibly have. And I think that's it.
And then please find out what drug the patient is taking and the last time he or she took the medication.
Yes.
Sometimes they've not taken it for 3-4 days. Patient needs to take their medication, you know. So it's important to know what drug the patient is taking and then if they've had it or not. So also that's also very, very important. Does
Cardiocare accept residents? Yes, we do. Just call the number that's been given to you. I think I don't know if you can see it now on your screen, but just call us and we'll tell you how to go about it. In hypertensive urgency, combination of amlodipine and olmesartan also a drug of choice? As we said, your antihypertensive, you're dealing with urgency, there's no problem. Just use your antihypertensive. But of course, we said it should be patient directed, you know, and start your medications gradually. There's no rush. You're not rushing to bring it down. You can gradually bring it down, but give the person a short appointment, and then so that you can monitor and gradually bring down the blood pressure. You won't say, oh, because it is 220, there's no symptoms. You just give all the, just say, take full dose, valsartan, full dose, amlodipine.
No. 1 month.
Start gradually. There's no rush. Just give the person a short appointment. The next clinic visit or the next day, rather, you can say, oh, there's been a reduction. Okay, do we need to increase further? You know, increase your medications further, just gradually, and then subsequently, your target is the blood pressure should be within the normal period, within 24, 48 hours. So no rush.
Then someone asked about lisinopril. This is an ACE inhibitor. And yes, you can use it also in hypertensive urgency.
But the only issue with ACE inhibitors, you know, the common side effect of cough. So it's either ACE or you use your ARBs if there are side effects. So just like lisinopril is cheap,
it's
cheaper, course, readily available.
Of course. And then
yes, you have CME points.
Yes,
okay, I think that's all. How soon should one discontinue methyl-dopa in an eclamptic patient who delivered, considering the increased risk of postpartum depression?
Yeah, so for methyl-dopa, you know, there are other choices as well. You have labetalol, you have nifedipine. So most times, most people don't really like to start with this. You can do your nifedipine.
You have other classes of drugs.
Yes, you can do your labetalol, you know, to the maximum dose. And if at all this needs to come into play, then you can actually go for it.
What's important is to bring that blood pressure down gradually.
Exactly.
So you have other classes of drugs to use.
Well, I appreciate the presentation on secondary hypertension.
Okay, so we'll consider that for another webinar.
That's noted.
Okay, I think that's it.
All right. Okay. Thank you. Thank you very much.
So thank you so much. Another webinar will come up the last Friday of the month. So thanks for joining us. Thanks for the response. Thanks for the questions. It's so obvious that everybody was paying attention. Yes. You're still about 113. Thank you so much. Thank you.
Thank you. Let's manage our patients better.
Yes, and refer to Cardiocare.
And know when to refer, preferably to Cardiocare Hospital.
All right, thank you.
Bye.